Hello and welcome to the Dementia Capable webinar series provided by the Rosalind Carter Institute for Caregiving in partnership with the Georgia Division on Aging Services. Before getting started, we advise having a pen and paper ready to write down any information and links to the resources as they are provided. Otherwise, you will have to view the webinar again to retrieve it later. You may pause the webinar now if needed. Remember that the link to the SurveyMonkey post-test will be pasted onto the last slide. The post-test will remain open for an indefinite amount of time. Please take it at your earliest convenience, though we encourage immediately following the webinar. A certificate can be provided when entering your email address at the end of the post-test. Today's webinar will be Living Not So Alone with Dementia, presented by Suzette Benford. Suzette received her bachelor's degree from the College of Charleston and her master's in clinical counseling from the Citadel. She worked as an individual, marriage, and family counselor for several years before entering the field of geriatrics in 1993. She has worked in a variety of settings with older adults: nursing homes, assisted living facilities, rehabilitation facilities, and inpatient geriatric psychiatric units. Suzette has been with the Alzheimer's Association, Georgia chapter, for 11 years and is the programs director for the Atlanta region. Welcome, Suzette.
Thank you so much, Elizabeth. It's a pleasure to be here. I want to thank the Rosalind Carter Institute for inviting me to do this webinar. I think this is a really important topic, and I hope that you'll get a lot out of it today. So here's what we'll be talking about today. We're going to address the prevalence of this issue, people with Alzheimer's disease and other dementias who live alone. We're going to talk about the particular issues related to this population, their care needs, safety issues, etc. We're going to talk about considerations for actually providing services for these folks who live alone, and also talk about resources for them. So before we really dive in, I wanted to just say a few words about the terminology that we'll be using. First of all, I wanted to just make sure everyone is clear about the difference between dementia and Alzheimer's, because I know that it's a very widely held misconception that dementia is just something milder that sort of may get worse and lead into Alzheimer's and become Alzheimer's. But I put the little umbrella there on this slide to just give you a visual reminder that dementia is the umbrella term. It just means a loss of cognitive functioning severe enough to interfere with your daily life that's caused by some medical condition. And so there are some treatable, reversible physical issues that can cause the symptoms of dementia, but then you've got the irreversible, degenerative causes, and there are a lot of different ones, but the number one most common one is Alzheimer's. It accounts for probably more than 60% of all cases of dementia. And so sometimes the terms are used interchangeably, but again, Alzheimer's is just the most common cause or form of dementia. So when I have people call me who say, my mom doesn't have dementia, she just has a little bit of Alzheimer's, or she doesn't have Alzheimer's, she just has a little bit of dementia, what we're really probably looking at is that mom statistically probably maybe has Alzheimer's or a related kind of dementia, but it's just in the early stage. And that's why the person's saying that mom just has a little bit of dementia. So I hope that clarifies for you the difference. Also, I wanted to touch on the difference between early stage dementia and early onset. So early stage, it refers to a person of any age whose impairment is just mild. So we could have an early stage person who is 81. They're 81, but they're just in the early stage of the disease and their impairment's mild. Early onset is a much more specific term that refers to a person in any stage of the disease whose symptoms appeared before the age of 65. So these are the people that were younger when they got the disease or developed the symptoms. So we're now trying to call early onset, we're trying to have a little shift in the language and call it younger onset to try to differentiate it from early stage. Okay? And then I just wanted to say a word about early stage versus middle and late stage dementia. What we're really referring to here is early stage is mild impairment, middle stage moderate impairment, late stage severe impairment. There's actually a 7-stage scale. It's the Global Deterioration Scale, or the Reisberg scale, that describes 7 stages of dementia. But you have to be aware when looking at that scale that everybody who has dementia is so different that sometimes people have the symptoms of more than one of the stages. And so generally we just use terms early, middle, and late. And sometimes we'll say, well, Mrs. Jones is in early stage, but she's in the late part of the early stage. And so the folks that we're going to be talking about today, the people who live alone with dementia, are generally going to be in the early stage, perhaps as late as the late part of the early stage, and maybe some people in the early part of the middle stage. And we'll talk more about that later. But I want us to just remember that what we're looking at is a disease of the brain when we're talking about specifically Alzheimer's. And I've included a little illustration there of a cross-section of a brain, the left side being the healthy brain and the right side being the brain of somebody with severe Alzheimer's. So we're really looking at brain damage and brain deterioration. And we have to be cognizant of the fact that as people progress, they really are less and less able to be functional, independent, and to do all the activities of daily living and that sort of thing. Okay, so moving forward, in this population that we're looking at, the people with dementia who live alone, these are some of the symptoms that we're going to be seeing. Changes in short-term memory is sort of the number one thing. Later on in the progression, people's long-term memory also gets affected, but in the early stages it's generally short-term memory. Their judgment is affected, their ability to plan and carry out activities, and this is huge. Very often the ability to manage their finances is impaired. That's often one of the ways that we first recognize that there's someone has some kind of problems with their cognitive abilities. And then visuospatial abilities are affected, gait and mobility. Sometimes you see people falling or are very unsteady. And, of course, problems with language, the ability to speak and understand spoken and written language. So when we're talking in a general way about providing services for this population, we're talking about a lot of folks. As many as a third of community-dwelling people with Alzheimer's and other dementias live alone. So in the CDC's latest BRIFIS report, they found that of all people in the state of Georgia, age 60 and older, about 30% of the people who reported memory problems live by themselves. And about 54% of those who reported memory problems had not even talked to a doctor about it. So we're talking about a very large population of people. This is part of a larger group of older Americans who live alone, but people who live alone are, in general, much less likely to have been diagnosed. There is less monitoring of the person. There's reduced recognition of changes by others, and very often that is for most folks the impetus for going to get a diagnosis. And so the safety risks in general are much greater for folks who live alone. So we got of the folks who do live alone with dementia, we have two categories: someone who they have someone who visits, helps them out with doing things, or at least checks on them from time to time, and then you've got folks who live alone who have absolutely nobody. This slide just gives you a visual illustration of what caregivers are doing for people with dementia. And so the blue is the caregivers of people living alone, and the pink is those who live with the caregiver. So you can see that people who live alone are getting much, much less help, particularly with ADLs, like on the left-hand side, the bathing, dressing, managing incontinence. Those folks who live alone getting much less help than with other things. But in general, for the most part, the needs of people who live alone are not being completely met. So when we look at how we're going to help the folks who are living alone, how we develop a care plan, there are some things that we need to consider. So first of all, first and foremost, we've got the safety issue. Is it safe for them to continue to live alone? Because, there are some people in the early stages of the disease, particularly those who have a little bit of oversight, who are perfectly safe to live alone. But the things that we need to be thinking about are if they were sick or they injured, would they be able to understand how to call for help? Would they be able to take the appropriate action? Then are there health problems that might put them at risk of harm? If they're diabetic, are they able to monitor their blood sugar, give themselves their insulin, etc.? And then relatedly, are they able to take their medications properly in general? Lots of times I hear family members say, well, I go over and I take her pills in the bottle and I come back and they're gone, so, she's obviously taking them. But, just because the pill bottle is empty doesn't necessarily mean they're taking them or taking them properly. Another consideration, are they able to store and eat food properly and safely? Sometimes food isn't refrigerated the way it should be, or people are often eating expired food, very expired food. Are they able to navigate the space safely? Are there stairs and can they maneuver? Or is there so much clutter that might be a safety hazard as well? And just in general, do they pose a safety risk to themselves or others? An example would be if somebody lives in an apartment building and they're smoking, are they able to do that safely? Or if they left the stove on and had food cooking, would that be an issue? So these are some of the considerations that we're looking at just in terms of, do we need to make an immediate change? And in general, these are the categories of safety risks. And we'll be talking more about these: self-neglect, malnutrition, injury, the medication errors, the financial issues, unmet needs for care, falls, wandering, driving, and the ability to respond to emergencies. Other things that we need to look at are, does the person have a diagnosis at all? Is there a diagnosis? And if so, how long has it been since that diagnosis has been made, and have they been going back to the doctor? What is their level of cognitive impairment, and what is their level of functional impairment? Because often these two things seem sort of dissimilar. There are people who seem very cognitively almost intact. They have few problems with memory, say, but functionally they're not doing all the things that they need to be doing for themselves. They're related, but also they can be independent of each other. Then, do they use social services? Are they eligible for Medicaid? What's their income? Is there a caregiver available, either informal or formal? So when we're doing things like the DON-R, and I wanted to mention that there are some really great webinars on the RCI website about using the DON-R with folks with dementia and how you can use it to kind of maybe capture those people. We're looking for their functional performance and their unmet needs of care. So in this population, the quality of the performance of their daily activities is often low, and the complex tasks are often more severely affected. And see, these are some of the more common unmet needs: companionship, activities, mobility, self-care, housing, in-home care, and nutrition. So we're going to go through some little examples here. Here's a quote from someone with dementia. Right now I do my own cooking, cleaning, laundry, and shopping. I'll do the checkbook and then my son will verify that it's correct. If I get goofed up, my friends and family don't give me a hard time. They understand. And if all that is accurate, that's great. That sounds like somebody who is living safely on their own and they have a son who's coming to check. However, we need to be mindful that self-reports are sometimes not accurate, and it's always better if you can get the reports of someone who knows the person, someone who can give you some additional information just to verify what's going on. And then the other quote is, this is a professional caregiver, without my help, she wouldn't eat the right foods. She'd probably go for something quick and easy, like grabbing Fruit Loops instead of something more healthy. And so we do have to realize that just because people are just getting by, they might not necessarily be really taking care of themselves in an ideal way. Here are some issues around safety. The most common reason my agency is contacted to help a person with dementia who lives alone is after a fall or hospitalization. That's from a geriatric care manager. And so we do have a lot of people who are sort of getting by, but then when they have a physical issue, that's sort of the deal breaker where they actually require help, and it's the point at which sometimes dementia is identified when it had not been before. And then another quote from a person with dementia: I did some organizing around the house and got rid of clutter, simplified my wardrobe, put labels on the kitchen cupboard. And so we're looking at, how can we create an environment for the person that is more safe for them. Decluttering is a big one, labeling things in the home, but still, it may be that the person isn't able to really understand the labels. So we need to look at, what we can do and is that safe. Now this slide talks about the driving issue, which is huge. The first quote is from a caregiving daughter. There have been a couple of occasions where she's gotten turned around. She was able to figure out where she was and got back safely on her own. The key is not to get too anxious so you can think clearly. She will sometimes ask for help, and I always tell her to call me. Well, if somebody has had a couple of occasions when they've gotten turned around and need to call for help, that is probably an indication that this person would be a good candidate for a driving assessment. There are driving assessment resources all over the state of Georgia. We have some on our website, which I'll share with you later. And, it's a huge issue. We see many, many, many cases of people wandering by car and getting lost, and people winding up in other counties and states. So it's a huge issue and one that we really need to be more aware of. And the other quote is from a person with dementia who is asking a trusted friend if they'd go out and watch how they're driving. And when she says I need to make a change or stop driving, I will. So that's one of the things that you can do, is have somebody who's willing to be an observer for the person and make recommendations about when it's time to have an assessment or to give up the keys altogether. So next we'll talk about self-neglect a little bit. It's the inability to consistently obtain food, clothing, shelter, medical care, maintain physical health and mental health, emotional well-being, and general safety, and manage financial affairs. So here are some sort of warning flags, some red flags, warning signs of self-neglect. Dehydration is a big one, and dehydration is a problem that a lot of people aren't aware of the severity of. When many older adults in particular don't get enough fluids. They just don't drink enough. And so when they get dehydrated, it can lead to really a cascade of other health problems. And so that's a huge thing to be mindful of. Also, malnutrition, when people just aren't getting the nutrition that they need. Maybe they've had a lot of weight loss. Then untreated medical conditions, poor personal hygiene, unsafe or unsanitary living conditions. Sometimes we see people who have forgotten to pay the bills and their utilities get turned off. When we see people wearing inappropriate clothing, that's very common, and that's a red flag. And, of course, if people have inadequate housing. Okay, so talking about self-neglect, here's an expert quote. Meals on Wheels is a fantastic program, but it doesn't work so well when the person won't open the door, when they won't open the food or eat it or store it. We've gone into houses where the food is sat on the counter because the person wasn't hungry or they didn't recognize they were hungry, and now it's 2 days later, it's inedible, but it's being consumed anyway. And so, that's another example of just because we have the service in place doesn't mean that that's going to solve the problem necessarily. Here's another case study. A woman called to report that her 65-year-old neighbor who lives alone had bruises all over and a cut on her nose. And they had taken the woman to the doctor before because she was so banged up. The neighbor got in touch with a sister in Louisiana who was the only known relative, and the sister said she just can't help. She's got MS herself. The police had also been to the woman's home 3 times in the last few days because she kept calling the police to report that a family had moved into her house and wouldn't leave, and that her car had been stolen when actually she'd had a crash in another part of the state earlier. The police told the neighbor they just didn't know what to do about the woman's situation. And so this is a pretty clear-cut case. And one thing that we should be mindful of is very often when you have a neighbor calling that's this concerned or has serious concern about someone who lives alone, that's usually a situation that we really, really want to look at carefully. And we need to be mindful that when we do go to the home and the person, their communication skills may be beautiful and they may be able to give you a great report and tell you they're doing just fine, it's very easy to be fooled when someone is in the early stage of dementia and their communication skills are intact. And so sometimes, you have to really rely on the reports of others and do a little bit of digging because you're not always going to get accurate self-reports from the person. Okay, now let's talk a little bit about financial exploitation. It's one of the most common forms of elder abuse in people with dementia living alone, unfortunately. And the majority of the perpetrators of financial exploitation are friends and family members that have a relationship of trust with the victim. Here's an ApS quote. Community education and public awareness campaigns don't adequately address the issue of preventing financial loss through theft and fraud, and yet those are some of the most prevalent cases we see in ApS, unfortunately. So here's a case study. A man called to report that he had discovered that his father, a widower, had been giving away most of his life savings. He was convinced that he needed to do this to inherit a large amount of money from a long-lost relative, or sometimes it's from someone in Nigeria. The son had been told by authorities that because his father had not been deemed incompetent, that there was nothing that can be done to stop this. So we have an issue when the person hasn't been adjudicated as incompetent, and we'll talk more about that in just a little while. We need to really look at the person's social ties and support that they receive from others. The importance of socialization is huge. At the Alzheimer's International Conference, which is just wrapping up in London as this webinar is being recorded, they found that a third of dementia can be preventable with lifestyle changes. There are 9 lifestyle factors that they say if you change them can make a huge impact on your risk of getting dementia. And one of those 9 is social isolation. It's a huge risk factor. So we need to really impress upon people the importance of social support, the different kinds of support they need, like not just someone to take you to the grocery store or someone to help you with your medicine, but also just socialization, social engagement, ability to be with other people and enjoy their company. We need to look at the opportunities for social interaction and how can we improve them. And we need to look at non-traditional support systems and think outside of the box. Think about neighbors, church friends, church agencies. Some agencies have senior visitor programs, and we need to look at all of those to just make sure that the person is not getting isolated. Here's a quote from a geriatric nurse practitioner. Often the needs of my patients with dementia who live alone are less about their medical condition and more about being connected to others as a way to avoid further decline in physical and cognitive health. Very smart quote. And a person with dementia says, there's no one here to monitor changes with me. So it's a social isolation problem and a problem with recognizing declines. So I wanted to just include some points from a conference that I just attended, observations from a geriatric psychiatrist who's also a neurologist who specializes in dementia, Larry Toon, who practices at Emory, said that he believes that 20 years from now, loneliness and despair or purposelessness will be a clinical diagnosis identified as a risk factor for dementia. So he believes that the medical community will really start taking this lifestyle issue much more seriously. He believes that addressing this issue should be included in the CDC's Healthy Brain Initiative, along with the other things that they recommend, like exercise, good diet, keeping your brain active, and that sort of thing. And at every stage of life, we need to find purpose and meaning. And for these folks living alone, when in the course of helping them, we need to think about helping them find opportunities or creating opportunities for meaning in their life and having a purpose. And even a Chihuahua, Dr. Toon tells a story about a woman who was very isolated and felt hopeless and depressed, and her family got her a little Chihuahua, and it totally turned her outlook around. So it can be something as simple as that, just to make a huge difference. Dr. Toon also recommends find the hearing aids and glasses and use them, because this issue of deprivation of your senses is huge. In fact, it's one of the 9 lifestyle risk factors that I just talked about to avoid dementia is hearing, particularly hearing loss is huge, and that is often something that we can do something about. People have their hearing aids but don't wear them, or they've got glasses and they're the wrong prescription. So, and the last thing is, with dementia, the world shrinks, people's world shrinks, so we need to try to make the world larger for people. Okay, so now we're going to move on to recognizing and diagnosing dementia. A standard, very thorough diagnostic process often requires or strongly suggests the use of the testimony of family members or close friends. It's very important to get their take on what's going on with the person and to get an accurate diagnosis. And obviously, physicians have less access to knowledgeable informants when the person lives alone. And without an accurate diagnosis, the physician is often going to assume that the patient is able to manage alone. So, we see this common scenario all the time where the older adult goes in to the doctor, they live alone, there's nobody to go with them, and the doctor says, how have you been? The person says, oh, I've been just great. And there's no way for the doctor to know that the heat's been turned off, they've wrecked the car, and they're having serious problems in their life. So we need to be aware, first of all, that, dementia varies so greatly from person to person. The symptoms can vary so widely. For example, some folks, as I mentioned before, their communication skills are beautiful, but their functional skills are not so much. Then, conversely, I'm working with a younger onset person right now who is, her communication skills have dwindled to almost nothing, but functionally she's still, able to really live alone and do just about everything for herself. And so I just made up a little sample scale for you. This illustrates one person. This is a scale of 1 to 10 in which the 1 would be very impaired and the 10 would be they're doing great. There's no impairment. So this person's ability to drive may sit at about, maybe a 7.5 or something like that. But their ability to do finances is way, way on the lower end of the scale. But then they can take care of themselves. They do their personal care for themselves. They communicate well, and they can do most of their household tasks for themselves. A lot of times people are tempted to assume that, for example, because they're not able to do their finances for themselves anymore, or because they're having maybe some problems driving, that they have impairments in all other areas. And so we just need to be very aware that, impairment in one area doesn't mean impairment in all areas. Here's another quote from a geriatrician. People with dementia living alone are at greater risk of missing appointments or not seeing a doctor for long periods of time because there isn't anyone to monitor and remind them. Unfortunately, the situation might not be recognized early on by the physician as an indicator that the person needs help. And this is huge because one of the most common symptoms of early dementia is that people often can't keep track of their appointments and they miss appointments. And the need to diagnose early is huge. Early diagnosis is everything. And so these folks who live alone, again, just are not getting diagnosed early enough. So we'll talk about some barriers to using services. Often the person who's living alone is very reluctant to accept the help, unfortunately. There's no identification of dementia, and they're just not connected to formal service systems. Then when we do identify a problem, there's no coordination among physicians or among professionals dealing with the person. Transportation is always a huge issue. People who live in rural areas often just have lower access to services. And income is also a barrier sometimes, and lack of support for state-funded programs that keep the person at home. Now we're going to pick back up this issue of competency and capacity. The legal framework to support people with dementia who are not able to make decisions for themselves is really insufficient in most states in the country. And of course, the law presumes that a person does have capacity unless they've been adjudicated as incapacitated. So this can cause some big problems. Some people with dementia who live alone and have not been deemed incapacitated really don't have the capacity to make all their decisions. And they sometimes need, people to get involved, and that can be unwelcome. But again, we want to be aware capacity is not all or nothing. You're impaired in one area, and it does not mean that you're still not able to, for example, sign a power of attorney. And a lawyer is going to use the standard of, do I understand what this power of attorney means, and am I able to adequately select someone who I trust to be the agent, the power of attorney. Okay, so one of the things that is inherent in our system is that we assume that a person is okay to do things if they haven't been deemed incapacitated. And so it includes the right to make unwise decision, which is sometimes described as the right to folly. And so we say, Mrs. Jones has given away almost her entire life savings to a son who is spending it on things that are not in the best interest of the mom, or really maybe even in his own best interest, but she hasn't been deemed incapacitated, so she has the right to do that. That's her choice. And we're not really looking at, has there been undue influence and that sort of thing. And so an expert in elder abuse prevention reminds us that the right to folly principle sometimes gets carried too far, and it gives some people a free pass to walk away with homes and estates. And unfortunately, we see that a lot, that people's entire life savings will get wiped out. Okay, this is a quote from a geriatric nurse practitioner. The person with dementia living alone can be so resistant to leaving what is familiar. Sometimes I'm not able to convince the person to attend a program like an adult day center. This is another common barrier to service use. Once the issue has been identified, how do then we get people to actually pursue and participate in something like this? One of the things that we often talk to with families is, if there is family and amongst friends, Is there someone who can really be an advocate to the person to say, hey, I'll go with you or I'll drive you? Or sometimes we might coordinate with the adult day center and say, if you could give this person an opportunity, quote unquote, volunteer here, we could present that as an option to the person, that they are in need of volunteers at the adult day center. But again, this is a barrier. It's often the case that people don't want to take advantage of what we're offering them. So here's some of the things that we can consider to enable the person to really live safely at home longer. We need to look at, getting help with the housekeeping, meal prep, transportation, etc. And we talked about thinking out of the box and not traditional service resources, but maybe other people in the community who can help us. Decluttering, of course. Cleaning out closets, kitchens, labeling, that sort of thing. Having a very trusted neighbor, and only a very trusted neighbor, having a set of house keys in case they get locked out, and to come in and help them if they had an emergency. Perhaps using electrical appliances that shut off on their own, like a curling iron or an iron, something like that. Install smoke detectors and check batteries regularly. Try memory aids. Very often people who are having difficulty keeping appointments are greatly helped by just sometimes putting something like a whiteboard on the refrigerator and making a monthly calendar and making sure that it's in a place where the person really looks at it every day. Making sure that phone numbers are in large print and right by the phone, including emergency contacts or ICE numbers in case of emergency in a cell phone. If there's an accident, that's one of the first things that the police will do is look for the presence of ICE numbers in the telephone. Form relationships with the bank and make sure that the folks at the bank are aware of the situation that the person has dementia. Especially with community banks, this is often a really good strategy so that it's another person to kind of be looking over the person's shoulder and making sure everything is okay. Bank employees are mandated reporters. And then enlisting a trusted person to help with that is valuable. Writing the person's address down and posting it by the phone, keeping a map and using GPS, all of these things can be helpful. Encouraging the person to ask for help when they need it and accepting help. That can be a barrier to service use, but we need to really coach people in asking for the things that they need. We can teach folks coping techniques and strategies. One of the folks that I work with said that he got very frustrated when he wasn't able to do the things that he used to do in the same amount of time. And when he finally just accepted that he couldn't do it as quickly and would take breaks when he was trying to do a task, it made all the difference in the world. And sometimes people just need a little bit of coaching for that. And then here's a website, dementiatoday.com. Living Alone is a great resource for more tips. Also, we need to look at the use of assistive technology to perhaps help people live safely alone longer, matching the technology to their person's needs and abilities. Barriers, though, may include what condition they have. Are they just unable to read or use the device? The design, is it too complicated? Some people just are not that great with technology and can't use them directly, and the person just might not be able to understand the instructions. But for somebody in the very early stages, these kind of things can be really helpful. A great example is GPS, of course. A person with dementia says, I took an indirect way home from the next town over and I got a little turned around. Now I keep a GPS in my car. Then a geriatrician says, monitors for the temperature of the house or fridge will alert a person to go check and call. I had a female patient with dementia living alone who somehow had the heat turned off during the winter, and she was hypothermic. I just attended a conference where they had all kinds of interesting assistive technology devices, and these are a lot more widely available now than they used to be. So there are remote temperature monitors and monitors for example, when not very much water has been used in a home, that can be, accessed from a remote location. All kinds of things that can be used, and in a minute I'll give you a resource for those. I also wanted to make you aware of some programs in other states for folks who live alone that can give us a lot of great ideas for how to support people living alone. The Gatekeeper program in the Pacific Northwest, the Senior Watch program in Florida, Dementia Capable Services and Supports in California, and the ALCare program in Washington, D.C. If you want to Google those will give you lots of great information. So now we're going to talk a little bit about policy and practice considerations. We really need to, as we talked about a little earlier, improve detection of dementia in older people who live alone. And Medicare now has an annual wellness visit where physicians can get paid to check a person out on a variety of different aspects of wellness, and one of those is cognitive health. And so they get paid to do a memory assessment and talk to the person about their cognitive ability and any changes they might have seen. And I think a lot of people don't know that, and so we need to get the word out more to particularly primary care physicians that this is available. On our website, which I'll give you later, there's a fabulous section for medical professionals that tells all about the annual wellness visit and about the cognitive tests that they can use. There's also a cell phone app that they can use that gives all of that information. And also, when we're considering the practice of providing services, we really need to personalize those services because, again, everybody is different. They have different needs and different preferences, and we need to try to respect those. Another word about improving the detection of early dementia. Just in general, we as a group of professionals in the community need to be more aware of the warning signs of dementia and the little flags, the red flags that come up that might indicate the need for an evaluation. Again, the early diagnosis is critical so that we can capture this early enough so that the person still does have the capacity to do their advanced directives, to be an active participant in planning for the future. Also, when people are diagnosed earlier, the medications that are available are more effective. And so this early detection is one of the biggest realms of research right now, is how do we capture people in the early part of the disease. So we're also, we want to be more able to assess for the capacity to live alone safely, make sure that we have effective tools for identifying people, including tests of like the MMSE, the mini-cog, tools for capacity. We need to be aware of the driving assessments and how to access those. And we need to also identify atypical gatekeepers to help us identify who's at risk. So people in the community who are coming in contact with people, like let's just say, for example, at a senior high-rise. Sometimes the maintenance folks or the adjunct services people who get to know the residents can really, really be helpful to us in identifying people who are exhibiting symptoms of dementia. Care managers, I wish that in Georgia we had more access to care managers. They're so helpful sometimes in following a person and making sure that they recognize changes and provide, the monitoring that people need. And when we do have access to a service like this, we should really assess the person comprehensively and holistically and look at the big picture. And they also need to be reassessed periodically because, people's rate of progression varies from person to person, and particularly with younger onset folks, people who are diagnosed before the age of 65, those folks tend to progress faster. Not always, but the norm is that they progress faster than someone who's diagnosed when they're older. So we really need to not just assess once, but then follow up. And we need to really start having conversations with the person to talk about what their needs are, their preferences and wishes, including end-of-life care. We need to make sure that they have advance directives, because we don't really do this enough with people, and everybody needs to do this really with their families. There's an initiative right now led by Ellen Goodman called the Conversation Project. And I encourage you to go to the website, just Google Conversation Project, and there's lots of information about how to have the conversation with people that you know, your friends and family, about end of life. In our society, we don't usually talk about it that much, but it's a gift that you give other people to make sure that they know what your preferences are. Years ago, I worked in nursing homes, and I saw so many families who had not had the conversation, and then the adult children were often left to make these really critical and difficult decisions without knowing what their parents' wishes were. And so that's very important. We need to, normalize the discussion about end-of-life care and really make sure that we get the kind of care and the level of care that each person really wants to have. And then finally, we really should be working together. Interdisciplinary teams are the ideal, where we collaborate on our care coordination. So now let's talk about actual resources. First and foremost, we have an issue with access to physicians, particularly in rural areas. And preferably the physician who's diagnosing someone should be a specialist in diagnosing dementias, but there are PCPs, primary care physicians, particularly those whose practice is they're older adults, who can also diagnose someone. Geriatricians and neurologists are, neurologists number one, probably geriatricians number two. Also, particularly if the person has a background of some other kind of mental health issue, geriatric psychiatrists are good resources. But, it is an issue sometimes for people to actually have access to the doctor, so we need to look at that. What are our resources for medical care? And then a lot of times we have people, especially younger people, who don't have any insurance. I work with a lot of younger onset people who they apply for disability and receive SSDI for their Alzheimer's or whatever form of dementia it is, but they have a waiting period for the insurance to kick in, and so they're left without insurance. So if you're lucky enough to reside in a county, for example, Fulton and DeKalb counties, those folks can be seen at the memory clinic at Grady. I know that there are some other places in the state that have some similar kinds of services. But one of the things that we have found is that if there are doctors who are doing any kind of clinical trials on memory-related disorders, they will often take the person in as part of their research, as part of the study that they're doing. And while they're in the study, they will also provide them with medical care. And they're able to prescribe them, get them their prescriptions that they need and do the other kind of medical care that they need. So that's another option for looking at care. So for people who have early dementia, there are resources out there. Across the state, there are early stage support groups. Most of them are in the Atlanta area, but there are groups in other parts of the state. There's counseling available. Also, we have funds. We have a grant to be able to give out this book to the people with early stage that we serve. It's called Living Your Best with Early Stage Alzheimer's by Lisa Snyder. And it's the first and the only book that I'm aware of that was written specifically for the person with the diagnosis. And it talks about really how to live fully and optimally considering the diagnosis. And it's a wonderful book that a lot of our folks have gotten a lot out of. And then we have some peer support and mentoring programs. We have a program where people with early stage Alzheimer's will call other people with early stage dementias, and it's statewide. So for people who live alone, that can be really valuable just to receive a call from somebody. It's twice a month, and just to check in to say, how you doing? Everything okay? And also, by the way, I really understand what you're going through because I'm going through the same thing. And then also across the state, we have social groups. We go to museums together. We have exercise outings, and we do a lot of social engagement programs like lunches. So later I'll give you the number for the Alzheimer's Association, and you can try to identify some resources in your area. Also, just to let you know, there's an instrument now to evaluate the financial capacity of people whose ability to make financial judgments has declined or is in question. It was developed by Daniel Marson. Dr. Marson is from the University of Alabama, Birmingham, and the tool is really meant to be used by professionals, but if you want more information about it, you can get it through the Georgia Division of Aging Services. And then we have the MedicAlert Safe Return program. It's a very low-tech program, but it works incredibly well. It's a bracelet identification program. There's a nationwide database of enrollees. So if someone goes missing, you call the number, and immediately a fax alert is sent out to all the local law enforcement jurisdictions with a current picture, so that they can be on the lookout for them. There's also caregiver jewelry. So, if a person does have if this is for people who live with somebody, if the caregiver leaves the person alone and they get into an accident and are unconscious, their bracelet will tell the first responders that there's somebody at home that needs help. So that's a low-tech program, but there are also a lot of different GPS systems out there now that work on GPS technology. And if you Google that, you'll see lots and lots of options for them. They're getting more common now than they used to be. And then here's some resources for online information. The Alzheimer's Store is great for looking at technology and all kinds of other things. But if you just browse through the online catalog, it will give you lots of ideas for devices and technology and other things that can help people live alone safely longer. Then, of course, we've got the Georgia ADRCs, the Aging and Disability Resource Centers, and then the last website here is our website. The national website is alz.org, and if you want to get to the Georgia website, it's alz.org/Georgia spelled out. And this is our 800 number. I just want to make you aware that the number is 24/7, and we really encourage you to have folks who are in early stage or their friends and family, anybody that you know really who is dealing with Alzheimer's or a related disorder, to give us a call, and we can talk to you about your needs, the individual needs of the person, and come up with a plan of care especially for you. This slide is a list of the references that I used in creating this PowerPoint, and then there again is our 800 number. So I hope everybody enjoyed the session today. I hope you got some useful information, and if you have any follow-up questions, just please feel free to call us. Thank you.
Well, thank you so much, Suzette. It was such a pleasure to have you speak on living not so alone with dementia. Thank you so much. Just a reminder for viewers that the link to the PostTest is pasted onto this last slide. Please take it at your earliest convenience. A certificate can be provided by entering your email address at the end of the PostTest. Please remember to view the other webinars in the Dementia Capable webinar series provided by the Rosalind Carter Institute for Caregiving in partnership with the Georgia Division on Aging Services. So thank you again, and we hope that you guys will join us again.